Good day, everyone. Thank you for joining us. To say that our world has undergone significant and lasting change would be the understatement of the year. From COVID-19 to the political climate to continued discussions on topics of racial justice and efforts for equality, we're experiencing new realities daily that adjust our perspective and our outlook. Close into today, in fact, right now, our experience with conferences has changed as we all go virtual. Our professional worlds have changed as many shift to working from home or from a car, in Paul's case. For many, personal lives have been turned on their heads, and our broader consciousness has been further awakened. For you all as healthcare leaders, this time of great change makes it all the more important to get refocused on what matters most, the consumers that engage with us. It is with this in mind that we've built today's conversation. My name is Justin Wartell. I'm one of the principals at Monigle, a creative experience company that focuses on putting the consumer at the center of decision-making, both in healthcare but across other industries as well. In fact, we built an entire report around humanizing the brand experience in healthcare, an annual study that deconstructs how to build and deliver better brand experiences. Our goal is to move people, and we hope that the dialogue today can help you to do the same. On behalf of the 150 people across our teams in Denver and New York, Monigle is pleased to sponsor the first virtual healthcare marketing and physician strategy summit keynote and the discussion that we're going to dig into today around the healthcare consumer. Before I introduce our panelists, we have a couple of quick procedural notes. First, attendees are participating in listen-only mode, but we welcome your questions. Type your questions into the chat pane on the screen, and at any time we'll respond to as many as we can. Second, please be sure to complete your speaker evaluations. All of the evaluation surveys can be accessed through the Summit mobile app. Your feedback is important to us as it helps to inform future planning for conferences. With that, I'd like to introduce our panelists. Paul Keckley is managing editor of the Keckley Report, a healthcare policy analyst and widely known industry expert. He's a frequent speaker and advisor to healthcare organizations focused on long-term growth, sustainability, and advocacy strategies. Kaveh Safavi is the Senior Managing Director of Accenture's Global Healthcare Practice. Dr. Safavi is responsible for developing and driving a strategy to differentiate Accenture's offerings for providers, health insurers, public and private health systems around the globe. Welcome to both of you. Thank you for being a part of the conversation, and I think we'll just jump in.
Great.
I think probably on the minds of most of our audience is the question of the crystal ball that both of you are carrying. What does the future look like? What does the future hold? Kaveh, I'd love to start with you. What do you think the future of healthcare looks like? What is that next steady state?
Sure. Thanks, Justin. Nice to see you. And Paul, nice to be here with you and share this time together. Well, crystal ball is probably a wild overstatement, but I do think that the last 6 months global pandemic has introduced some new dimensions to what has been really healthcare's modern day problem. So access, affordability, and effectiveness, still a challenge. COVID didn't solve it. We're still going to have to deal with that even as we wrestle this current pandemic to the ground. But the truth of the matter is that we've never experienced, again in modern times, like last 100 years, less than 100 years, a global pandemic of this scale. And it's introduced some things into both the psyche of individuals, citizens, as well as some opportunities and challenges for business that will be part of the healthcare landscape going forward that weren't there necessarily as components. The two that I think stand out the most are distance and resilience. The concept of distance is really interesting because we now understand the fact that diseases can spread, and the simplest way to reduce that spread is to maintain physical separation and cover your mouth. But physical separation as a function of protecting people's health is now going to become a regular part of considerations, both in healthcare and non-healthcare settings. And if you take it one step farther and you think about virtual healthcare in the United States and think about pre-COVID, the business case for virtual healthcare or telemedicine was largely either around aspects of access or preference or maybe some economic affordability. It was never done because we thought that that was the only safe way to have an interaction between a doctor and a patient. We've now introduced the concept of distance and safety as an additional reason for having a virtual relationship beyond just preference. So that's one. The second part of it is really the concept of resilient organization. So COVID has tested all parts of society and asked the question, are you resilient enough to withstand the shocks of the system when society has to go into a complete stay-at-home mode for an extended period of time? It really plays itself out in three specific areas that I think we're going to see in healthcare. One is going to be around the supply chain, one is going to be around technology, and one is going to be around our workforce. But we know that our supply chains have been optimized for the lowest cost for the last 2 decades. That meant concentrate your purchases in a single place and move it to the lowest cost of production, and then COVID showed up, and it cut us off. And we're now going to have to introduce resilience as a factor in a supply chain beyond lowest cost, multiple sources, and closer to where you need to use them. So that's going to be a completely new way of thinking that we haven't thought about before. On the technology front, organizations' ability to scale up and scale down across all of their capabilities is really emphasizing technologies that are available primarily through public cloud. And what we're seeing organizations do is they looked at public cloud as something nice to have and maybe for part of their business, but COVID has forced organizations to reorder their priorities and bring that forward as a foundational requirement for whatever shock is going to come in the future. And then the last is the concept of a workforce and this idea not only of who works for you, where they work for you, do they work from home or do they come to the workplace, but also how do I have elastic capabilities? What if I have to get a workforce to grow quickly or to shrink quickly? So we're seeing lots of thinking about the workforce. So those aspects, resilience and distance, are really new considerations laid on the old ones.
And how about for you, Paul? What does your crystal ball say?
Kaveh is always so articulate. You know, I see it through a similar framework, but kind of at a more in the trenches view. I see 2 or 3 things that are about the system of the future. One is this concept of systemness. What we've learned from the COVID is that the public health system and the health system operate independently and are not integrated. So does the policy world recognize that that's a disconnect that needs to be solved? Then how do you go about doing that with state legislators, since public health activity is really funded more at the state and local level than it is the federal level? A second area I spend a lot of time on is just anxiety. Where do people get their information? What would prompt them to consider having their screening mammogram done? They had scheduled before things shut down, or even a joint replacement. A lot of science coming through the pipeline on what prompts people to feel more comfortable. A lot of tools being developed with technology to help them overcome some of their anxiety, but at the end of the day, the majority of folks are anxious about the system. And then a third area that I think of is the politics of healthcare, simply because we're, soon to elect our next president or re-elect the current president. And healthcare is going to be the centerpiece of that vote. If it wasn't coming into COVID, it is now, because it exposes all of the flaws of the system. And Kaveh, this is one of the angles of this that I really am intrigued by, is this newfound activity of the Microsofts, the Intels, the Facebooks, the Apples, in verticals in healthcare, actually coming into this system and saying, we can address that anxiety that people have better than the incumbents. We have better ways to serve the needs and wants of consumers than some of the people that have been in this for years. And what's kind of interesting, Justin, is how much private equity and strategic investment is following these alternative systems of health that are popping up. So that's kind of where I am.
Well, let's unpack a couple of the things that you both were just talking about from a distance perspective to start with, Kaveh. When you think about distance being rethought, what do you think that's going to mean ultimately to the consumer's experience with healthcare?
Yes.
How's it going to impact the way that they engage in a different way?
Well, it's going to be bigger than healthcare because what happens now in our psyche is this recognition that you can catch a disease if you're physically close to someone who has a disease, and it's kind of a big deal. So let me use a metaphor. Before 9/11, think about what happened after 9/11. After 9/11, the concept of terrorism and the relationship between terrorism and airplanes was seared into our psyche. And even today, if you could just walk on a plane and no one checked an ID and you didn't go through a metal detector, we think that's nuts. We probably wouldn't ride on that plane, even though nothing has happened in 2 decades. Same concept is here, which is that people are going to recognize the fact that humans can spread disease with each other, and in the absence of knowing that it's safe, people are going to want to keep their distance. How does that play itself out? There are hospital systems right now that went to virtual waiting rooms to deal with COVID as a requirement, not as a preference. Now they're rethinking whether or not they should ever have waiting rooms. If the question is, well, maybe that's sort of an archaic concept, both from a convenience and a safety perspective. I'm not suggesting it's an all or none, but no one would have, that thought wasn't the same thought 6 months ago. And so we're going to begin to see much more about that approach. I think health will become an important part of many businesses, in fact, all businesses. It could be an issue with a building, right? Is the building safe? Is the air supply safe in the building I work in? You go to a retailer. I can't even imagine what the transportation industry or the hospitality industry is like. I would imagine that they will compete on health and infectious disease for the next half a decade coming off of COVID in order to get people's confidence to come back and go back to their establishment. So I think that that's really probably one of the most persistent aspects.
And Paul, Kaveh just mentioned waiting rooms as an example. What do you think some of the other, maybe more challenging, archaic, to use the word that you use, or potentially archaic aspects of the healthcare experience do you think are ripest for change?
Well, it's a good place to start with that regrettable, embarrassing term we use for the reception area, a waiting room.
Yeah. Like
you're expected to wait.
Right.
I think we're not real serious about consumerism in healthcare. I think it has hot spots where there's more activity. But I think we're still a B2B industry, and we don't think that consumers are going to play an active role. I think that is the cushion that supports a lot of the belief around a Medicare for all option. If the system's so complicated and people can't figure it out and can't make decisions for themselves, and the payment mechanisms are confusing and prices aren't transparent, that system doesn't work for me. I'll try something different. And that different may be this Medicare Advantage for all or Medicare for all model. I don't know. I'm puzzled by all the attention consumerism gets in bits and bytes, but the business model of the system really isn't built around B2C.
Mm-hmm. I agree with you, Paul. Can I just add a point here, Justin? So pre-COVID, we do our biannual consumer survey looking at consumers' attitudes toward digital health. And we were just about to publish it when COVID closed everything down. But what we had found was that adoption of digital health solutions, so think a broad variety of them, had basically plateaued over the last 2 years. So the amount of consumer adoption had gone up in 2-year increments, and then it had leveled off. And when we looked at why, there were 3 big issues that really were driving the leveling off. The first was a bad experience turned people off. The second was that it wasn't insinuated into the workflow, so providers wouldn't recommend it. And the third reason was increasingly concerns about trust and who has my data, those sorts of things. Now, what's interesting about COVID is COVID forced a bunch of adoption, particularly around telemedicine. But it's not axiomatic that it's going to stay, to Paul's point. There are lots of forces that might cause it to go back. For example, nobody redesigned the digital experiences in the last 6 months to make them better. So if we're serious about consumerism, we're going to end up having to address that issue, or we'll just see a retrenchment, a large retrenchment back to the pre-COVID era, as an example. The one thing COVID did do is it forced workflows to adapt to technologies, particularly on the doctor side, and that's probably going to be the most persistent gain, likely just because doctors are used to something that they thought they were alien to. And then the last point is this issue of trust and who has my data. So connect that back to Paul's observation. The last 6 months has made us more dependent on digital platforms for our services, which can only make our concern about who has our data more, not less. And so the response to that issue is going to be critical to the question about whether or not these gains persist, because while we depend more on big tech, we're also as skeptical as ever about big tech and what they're going to do with our data.
Yeah, that was the reason Zuckerberg was kind of zeroed in on by the House committee the other day.
Absolutely.
It's a bigger issue than I think we appreciate. Privacy is not the same as security. And most individuals begrudgingly acknowledge that they've lost control of privacy. They've lost it. And they wonder who's got access to things that they wish they didn't have. So it's a really good point.
Yeah.
In the spirit of consumerism, there's probably a lot of people listening to this that would say, if there's one thing I could change about the orientation of my organization, it would be to make them more consumer-oriented, to help shift our mindset to be more consumer-centric. So given the limitations, Paul, that you just teed up around the system's not built that way, the structure is not built in a consumer-oriented way, we're still a B2B industry, what can the strategists, the communicators, the marketers that are listening here, what can they do in their organizations to try to change that, or at least incrementally move their enterprises more toward that consumer mindset?
Well, it's interesting right now, if you take the 800 different measures that are used to evaluate urgent care clinics or hospitals, and these are part of their incentives. So this would include things like HCAHPS and others. There are about actually 780 measures that are used. And when we've analyzed those, about a fourth of the measures involve, quote, the patient experience. So out of just sheer self-interest, organizations have to be worried about the user experience, which is kind of an analog to consumers. However, the consumer experience may have nothing to do with the efficiency and effectiveness of the care provided. So that's the trick here. How do you maximize a consumer experience to either minimize a penalty or maximize reimbursement or get a star rating that gets you what you want? But at the end of the day, recognize that what consumers know about healthcare is still precious little. They're basically ignorant about the healthcare system. And, you can take that two ways. You can say we really need to educate people about the system. Really? Do we really want them to see how sometimes wasteful we are? How much of the care we deliver that's not evidence-based, or the lack of medical adherence to the evidence on the part of prescribers and so on? I'm not sure the system is ready to be a consumer-driven system. I'm also certain that non-traditional people in the system think that's its flaw. We've got to get there. We're going to force that. So I think that's going to be employer-driven. I think insurers are going to pile on and say, you folks, you incumbents, you're really comfortable in this B2B model, and like the fact they're patients, we think that's a root cause of many of its problems. So we're going to alter that model.
Justin, let me just add, I think one of the challenges we have in healthcare is we tend to generalize from a single experience to the whole.
Yeah.
And what does that mean? That means that a lot of times doctors would say that the archetype of healthcare, is complex trauma in the emergency room. And since you can't make that consumer driven, you can't make healthcare consumer driven. And the other side of the coin is a young, healthy person who never experiences anything other than, generally speaking, elective care, who doesn't understand why the system doesn't work for them. So I think that the challenge is that we have to recognize that heterogeneity, and that's part of it. Now, the burden comes to the delivery system, I would say, because if we're going to really be built around the needs of consumers, we have to have a mindset that is really that care is on the terms of the patient's terms, not our terms. And I would argue that we have done ourselves a disservice in the last decade or two in our consumer-centric conversation, in that we haven't really clarified the center of gravity in that dialogue. And when we talked about patient centricity, what we really meant was the equivalent of me taking my dog out for a walk and giving the dog more leash, and then letting the dog think it's taking me for a walk. But the truth is I had total control. So our definition of patient centricity was, I'm in control, but I'm giving you a little more freedom on the leash, versus I got the leash and you have control over the leash, which is the reversal of the metaphor. So a true patient-centric is who's walking whom, or, in Don Berwick's concepts, he talked about 15 years ago, who visits whom when you see a patient at the bedside, right? Are we visiting the patient because we're a guest in their lives, or are they visiting us because they're in our building? That's the metaphor issue that we struggle with. I would argue that if you can get someone to answer that question honestly, that's the first step. And until they can answer that question, they're still building a system that is really delivery system oriented.
Oh, yeah. I just recall a conversation in 2010 when we were in the middle of the ACA in the White House, kind of their health reform group with the trade groups in the White House Office of Health Reform. We had a robust several-hour discussion about should health policy move us toward an activated consumer, or should it neutralize all of the forces that limit their ability to be engaged and informed, and then get that far in this bill and then come back with more. And the Affordable Care Act essentially says we have to take barriers away, but it doesn't go full bore to an empowered consumer. And that's simply because the politic of the day was that most consumers don't want to be engaged. So that's the politics of that. They'll say it on a survey, but then not behave that way with their money or their activities. And the second thing is certain populations of consumers face barriers that make it even difficult to be engaged. So what the law did was really say we need to take away some of these barriers, not necessarily activate consumers. There was only one behavior in the Affordable Care Act that was singled out that's specific to a consumer's behavior, and that was smoking. They actually penalized smokers and said that's a behavior you can control. But the rest of it was kind of left off the table. And I wonder if that's one of the flaws that'll be addressed over the next 2 or 3 years.
Kaveh, I'd love to get your perspective there. He mentioned the idea of consumers not wanting to be involved, not wanting to be engaged. Mm-hmm. Do you think that that's going to change going forward? Do you think that the challenges that you teed up around distance, an organization rethinking itself and some of its delivery mechanisms to be more resilient, do you think it will result in consumers wanting to be more engaged?
Yeah. Well, so I think it's important, again, to not ascribe a single concept to all consumers. I think in some cases, we have individuals, for example, who want control, but then delegate that control back to learned experts, right? So they want the right to have that. They want a right to delegate to their doctors or their caregivers, but it's still their choice. And that often feels like they don't want control, but really what they want to do is authorize you to act on their behalf and then take it back whenever possible. Also remember, there's a lot of information asymmetry in this process, and even the smartest of us, there are points in time where we know that we simply aren't going to be in a position to make the decision. So particularly as it results to clinical decisions, I think that issue tends to be a delegated decision. We get a little bit, we conflate some of the issues of clinical judgments with value, particularly around societal value and whether or not something is worth it. And we talk about things like cost benefit, because now you're having essentially a judgment as to the value of a productive day or a productive life. And that's an open question as to who gets to weigh on those scales. Is that if you go to for example, in the UK, the NHS, for all intents and powers, the care system is empowered has been authorized to make those decisions, and frankly, the citizens are fine with it. But in the U.S., that would never fly.
They're more satisfied with that system than we are with ours.
Yeah.
And the Canadians the same, but you can't cut and paste any of those systems into the U.S.
Right. That's the whole point. It's individual values. But the question is that's a weight. That's a weighing of the scales, and who's in charge of that is even more complicated, because you might argue, and some would argue, it's neither the doctors nor the patients who have the right to weigh that scale. It's some other societal or governmental interest. So you've got a lot of that going on. I think the hard part of this is healthcare is more complicated than medical care and medical decision making. There are many moving parts. How long should I wait for a test may have no clinical consequence, but it may be, it is in fact how people judge whether or not the system is working for them. And if you just rely on if you don't die, it's inconsequential, therefore it's not of your concern. Like, I get to decide, and as long as you don't die, it's not your problem. That doesn't work in pretty much any modern society anymore. And so that, I think we're struggling with lots of issues here. And I would be careful not to oversimplify it. But I think that in all societies, as wealth increases and education level increases, and the middle class increases, Maslow's hierarchy concepts make sense. Self-actualization is tied to self-control. There isn't a society in the world where the middle class doesn't want more control over aspects of their life. So the direction of travel with education and wealth is people want more control.
So Liz,
I hope they know what to do with it. No, I think he's right, but that's a two-edged sword. Do expectations run counter to reality? We all, I remember doing work on evidence-based care, and what does that concept mean, and how often do we practice it? And we did a series of focus groups around the country and found out that most people were convinced that the care they were being diagnosed and directed to was evidence-based, and then found it surprising that they didn't want to know if it wasn't. So a little bit of blind faith, maybe we conditioned that into the system, and now the nature of disease is forcing us to re-engage people about their own health. And it's not about going to a hospital. It's about a number of factors beyond facility-based care. We can't do that unless we engage them as partners in this process. But I was just kind of thinking about the Medicare Advantage plans. Not surprisingly, that's the platform that's adding all these supplemental benefits and over-the-counter remedies and social determinants to that platform. And at some point, an MA plan is going to be on the table that says, and we're going to share savings from unnecessary medical cost with the individual member, so they have skin in the game. I think we're kind of moving in that direction.
And just to add one more thing. I think in COVID it really reminded us of this. The general theory is that choice and allocating scarce resources are basically in conflict with each other. And if we have a scarcity of resources, then you can't give people unfettered choice. Someone has to be the allocator, right? And we saw these issues come forward explicitly in the triage functions that occurred in the early days of COVID. Ventilators, even testing is like that right now, right? Not enough resources, doesn't matter what you want, you've got to allocate it. There's a social allocation that goes on. We'll forever struggle with that, but I think that ends up, again, being something that's on the extreme, and to take that concept and say, since we know there are circumstances in the extreme where choices have to be mitigated because of triage and resource allocation, that should be the case all the way through, is I think where this breaks down. That's the argument, that's where it breaks down.
Let's dig a little bit deeper into choice, and borrowing something that you talked a little bit about earlier, Paul, this notion of anxiety. In the research that we're doing on behalf of healthcare systems and understanding the market in this COVID world, and the research that you each are doing in some of the national perspectives that are available, safety remains a significant issue on people's minds. But with everybody talking about safety, have you found that there's an understanding or an interpretation of safety that's helpful for people? And then for the communicators and strategists in this audience, beyond safety, where do we go next? What are the things that might be on the minds of these consumer audiences? And again, don't mean to generally categorize, but from a broader mindset perspective, what's going to move people when everybody's talking about the same thing?
I don't think they are talking about the same thing. I think one of the interesting unintended positive consequences of COVID is there's a more granular view of what safety might look like. I think if it's merely the fact that sanitizers are on every wall, but some aren't full. I remember reading a statement once about one of the airlines, and they said, and this was in their annual report, it said, a stain on the put-down tray means engine maintenance is inadequate. And that kind of stuck with me. So I think there's more awareness of a wider range of safety-related issues than maybe when IHI started putting out its punch list, and we had crossing the quality chasm and central line infections and all the things we always pay attention to. I think they're looking for more now. And I think that's a good thing. Safety, though, may not be the surviving factor for healthcare organizations. The economics of healthcare permit safety to keep you in the game, but they don't let you stay in the game for long. You've got to have other strategies, I think, to get beyond just, we're going to make sure that we don't kill you or you don't walk out of here with an infection.
And I'll add to that. I think, Paul, you're absolutely right. There's no question. It's introduced a level of nuance and complexity that I'm not even sure we're capable of handling, but it's forcing us to do it.
Yeah.
The disease, we simply don't know enough for there to be some level of confidence for any healthcare professional to say, do this and you will be safe. And what's happening is because public health can only provide a certain level of information that looks more like, you might get it, you might not get it. If you get it, it might be a big deal. It might not be a big deal.
Right.
Institutions, non-healthcare institutions, have to figure out what they're actually going to do when they can't get information from healthcare that's specific enough for them to do anything other than implement it in whatever makes sense. So, I mean, the conundrum of public schools opening is unbelievable. And it's not a simple problem. It is absolutely not a simple problem. And there's no way that you can ever guarantee anyone that they're going to be totally safe. And yet we also recognize that nothing in life comes with the guarantee of total safety. But it's gone from a minimum standard to this continuum goes through your daily life, all your normal activities. So it's really testing our capacity to understand concepts of risk at a personal level and deal with it when there's very little information.
Be careful what you pray for.
Right.
Well, I'd love to circle back to something you mentioned earlier on and the role of technology in the better ways that organizations are, newer organizations, new enterprises, we call them disruptor brands that we've been keeping an eye on in the healthcare industry. Where do you think there are the places that some of these technology brands, these private equity supported enterprises are going to be able to chip away at the broader healthcare industry? Where do you think are the ripest areas for that kind of action?
In the context of private equity?
Yeah, or technology, which you had teed up as well.
Yeah, the two are not on the same path in some ways. Private equity tries to get its return in 4.7 years and get a 20% CAGR on their money and get out and let somebody else play the long ball. So they look at technologies that have a simple app or a simple solution that can be sold to somebody else, a strategic investor. More broadly, I think technology is solving simple problems. I'm impressed. I was on a call with one of those big technology companies earlier this week, and the questions of the design teams are very specific to a problem that can be solved simply. And we kind of lived inside the industry where its complexity was almost a shield against people getting too nosy. And now we've got these technology people saying, I'm just going to peel this back like an onion, one little simple solution at a time. And I think that's the way I'll reflect on this era more than anything else, that we were embroiled in meaningful use, and it's Cerner or it's Epic or it's whatever ERP platform, and it's big, hairy, audacious system IT stuff. And these folks look at this and say, what little problem can I solve? And what can I do that takes a little cost out of the system and a little headache off the operators? And then they let everybody else do the development for them. What's always interesting about these big platform players is they want all the innovation to come from the developers, all the OEM guys. And once somebody hits a home run, they're tethered to their platform for life. They encourage that. And I think that's something to think about. If we look back 5 years from now, well, the things that we think frustrating be simple problems that were solved by a technology company. I suspect more than we can name.
And are there any of those smaller problems that you see a solution coming pretty quickly that get you excited? Things where you're like, yeah, that could be powerful.
Well, access to my medical record in my smartphone with real synchronous flows of data from my claims record the insurance company has, and from the supermarket where I got my functional foods. Yeah, I think that's one of those huge game changers. It's going to be hard for a lot of incumbents to deal with that because we actually still charge people to make a paper copy of their medical record. That's how backward we are. But that's one. I'm sure there are lots and lots of others. I'm kind of amused by the price transparency debate right now, both on the drug side and on the hospital side, because we've never really wanted to come clean about prices and costs, but we go full bore to be a top 100 hospital or a top 50 hospital. I was reading U.S. News Honor Roll was just put out this week, and none of the southeastern hospitals are in their honor roll once again. They're primarily northeastern and western. I wonder if people are going to get tired of all of our kind of puffery and use their own technologies to decide what's real and what's fake.
Kaveh, I'd love to pass it over to you for thoughts on that question. Where are the places where you see these newer organizations or technologies chipping away at the traditional healthcare structure?
Well, I think broadly, there's a lot of opportunities that are taking place behind the scenes in business operations that are not really necessarily the thing of consumers, but for example, there's the modern technologies that combine artificial intelligence and natural language processing and the ability to read a document and find terminology for all kinds of business purposes is enormous labor suck, and is actually one of the greatest source of waste, administrative waste in the healthcare system, getting data out for the purposes of payment and quality reporting. And technology now makes it possible so that you can substitute for the work that people are doing. And the technology actually frees them up to do real work and also gets the job done more efficiently. On the flip side, one of the more interesting use cases that will eventually happen, and it's being refined right now in the market, is the ability to listen to a conversation between a doctor and a patient, make sense of that conversation and capture that information. That data capturing, I'm not talking about transcription, currently consumes about 10% of a doctor's time in waste. This is well documented, 10% wasted time entering typed data in, because that's the only way to take a conversation and convert it into a structured data element. And then you can also generate a workflow. So we know, for example, that a doctor and a patient can have a conversation, and it is possible that as that conversation is occurring in real time, the record is being updated accurately, and it understands that the doctor is ordering a medicine or a test, and that test is being executed at the same time, so that there's all those handoffs, all that paper writing goes away. And that's the technology that's existing necessary to do that is here, and it's being refined, and we're now actually putting it in real tests in those situations. So we are likely to benefit from that kind of an experience in the next 3 years.
Thank you. As we get to the end of our conversation today, I'd love to open it up for a general lesson learned perspective. So from each of you as we close today, if there was one idea or strategy or topic or question that you could impart to the strategists and the marketers, the communicators, the brand people in the audience here to prepare them for the future, what would it be? What would you want to pass on? Maybe Kaveh, I'll start with you on this one.
Sure. I think that we actually have to build an organizational capability to test and learn. And the last 20 years, we've actually spent all of our time telling people that the primary objective of an organization is to take all variation out and to follow the rules, largely in the interest of both safety and affordability. But what we learned pre-COVID, because technology changes the nature of work in a way that you actually have to make it very specific, and COVID and the uncertainty of COVID, is that there are no easy answers. And when you're dealing with uncertainty, that's either manufactured, let's say new technology, or imposed from an infectious disease, the only way forward is to be able to test and learn. And that mentality is actually an anathema to the way most healthcare organizations are wired right now. So that's a leadership challenge, and that is a management challenge. But I think it's going to be critical for us to move to test and learn as a way of doing business.
Yeah, coming from a non-healthcare background, my work before coming to Monigle was in retail and consumer packaged goods, where the mindset of test and learn and move forward in that fail forward fast mindset was much more natural.
Right.
And the ability to start to think in that way could be transformative, at least in getting us to move at a different pace. Paul, how about from your perspective?
What keeps me awake is defining systemness. We don't have it. We've got sectors that are independent and they feed at the same trough, but they try to stay out of each other's turf. So the one thing I think we have to define and then implement is systemness in healthcare. And systemness involves these handoffs and this information sharing with individuals and their households, that standard course of business. We've got to get past each sector in healthcare defining, quote, consumerism as, quote, the user experience, then get to a level of understanding that individuals play key roles in the health system. And it doesn't start in the admitting office or the ED. It starts in their homes, and it starts in their schools and their workplaces. And then take advantage of that opportunity to reset the table around systems of health. And I think that's where some will go, and others will fight the demons of we're resistant to change. We just can't do it that way, and find every reason to say that that's a stupid idea. And while they're doing that, there'll be some non-traditional players that come in and do it. So that's for me the big idea, systems of health.
It's also a great way to put a cap on our conversation today, because in many ways you're talking about expanding our purview from one of patient to the broader notion of consumer and consumerism, which was what we brought the two of you together to talk about today. But I want to thank you both for the time and the discussion today. With that, we'll open it up and try to tackle questions that have been posed through the chat.